Hello everyone. In this video I am going to demonstrate the augmentation of ACL or remnant preservation technique. You can see this is 3-week-old ACL knee injury. There is a peel off of the ACL from the femoral attachment. I am now checking with the probe, and the part of ACL fibers only is attached to the femoral area, and only some fibers ACL is there, and because of fraying of the ends of the ACL, I am not thinking of reattachment of the or ACL repair. Instead, I am going to reconstruct the ACL and place the new ACL graft in front of the native ACL. I am checking with the anterior draw test. Now clearing the lateral wall with the underwater cautery. Now I have to create a space in the femoral area footprint so that the ACL graft can be passed. Because of ACL, sometimes we may not be able to see the posterior wall because capsule and the part of ACL is intact. So here I am now checking the from the medial portal and creating the accessory medial portal. You can clearly see the remnant ridge, resident ridge, bifurcate ridge, and our femoral tunnel has to be behind this bifurcate ridge in the posterior most quadrant, just anterior to the posterior wall. You can see I am marking with the diamond trip dilbit of the arthrex, and this is just anterior to the native ACL, which is remnant. See, I am working from the accessory medial portal and visualization of the femoral area from the medial portal. This is again from the anterior lateral portal. After marking, I shift the portal to anterior lateral, and drilling is done because it might be overcrowding in the when we are drilling. This drill is showing about 35 mm. I cross check, I pull it back, the diamond trip drill bit, and socket is being prepared. This is about 8 mm. Graft is being prepared in the on the back table. Socket is about 25 mm of length. It is again anterior to the native ACL. You can see 20 is gone, 25 is now going inside. Okay. Now after the socket is prepared and ethibond is passed from the bead pin, now we'll come to tibial preparation. Now Amer tibial jig is being placed on the ACL. Guide wire is passed on the ACL. You can see the guide wire is coming just exactly at the center of the native ACL, and we are going to prepare the socket, and again 8 mm. You can see the socket is prepared, but you are not able to see the tunnel because it is covered with the ACL. I am clearing the socket. Now suture retriever is being passed from the center of the ACL, and ethibond is being pulled. You can see that we have to pull the ethibond from the center of the ACL so that the ACL wraps the graft. The native ACL wraps the graft which we are going to pass. Now you can see the button. We are passing the tightrope, and I am clearing the part of the ACL with the probe. As we had seen, the length of the lateral wall was 35 mm. It is marked at 35 mm on the tightrope. Now I will switch the portal to anteromedial portal, or medial portal. To check the flipping of the button, I will see from the tunnel and confirm the flipping of the button. See, the button is now flipped and it is showing the mark which you have made. You can see, if seen from the medial portal, our femoral tunnel is exactly behind the ridge. Now this ACL is being passed and the native ACL is around. We are passing the graft in the center of the ACL, so that the remnant of ACL is being preserved and our new graft is around, is in the middle of the ACL. We have marked the graft about 2.5 centimeters. That is where our socket is going to end. Means we have done 2.5 centimeters of the socket. You can see the ACL graft and the native ACL which is around, and you can see tibial side ACL we have not disturbed, and our graft is in the middle of the native ACL. I am confirming the position, and now we are going to fix the ACL at the tibial side. This completes the augmentation of ACL. Thank you for watching.